Thank you for joining me in Australian Fitness Network and presenting this curriculum, Insights into Functional Training. This program will explore the characteristics of human movement, functional anatomy, and how it differs from anatomical anatomy. In Part 2, we will dive into the flexibility highways and how integrated flexibility is highly dependent upon full body movements to attain the most efficiency in human movement. This then will lead us into the third module, which is perspectives on functional assessment and how to collect useful information. We will discuss how chain reaction biomechanics impacts full body actions and what to do with the information gleaned from the assessment process. Part 4 is program design and addresses a remedial to progressive approach to create effective and personalized programs based upon the issues and information gained from the assessment process. The final part of this curriculum is special populations, addressing the issues and strategies of the three most common injuries: low back pain, knee problems, and shoulder pain. Additionally, we will address strategies for iliotibial band pain and what is commonly called piriformis syndrome. As special populations can concern a myriad of maladies, this curriculum has limited its content to those subjects stated above, as these are commonly seen by the personal training and rehabilitation industries. I hope you enjoy this program and can add a few tools to your personal training, corrective exercise, and physio toolbox. Thank you for taking the time to add this to your professional arsenal. To date, many descriptions of the term functional training have been discussed. In fact, many vendors use this terminology for their equipment descriptions, and nothing could be further from the truth. In order to describe if a movement or exercise is functional, there needs to be certain criteria to provide clarification if a program is functional in the purest sense. Certain issues must be addressed when developing the client's design. These issues must address: what are the client's goals? Is the program task and goal specific? In other words, is it meeting the required actions to accomplish a specific task? What are the limitations, compensations, and idiosyncrasies of the client? After we address these issues, then we can consistently describe characteristics of human movement or functional training as the following. Eccentric before concentric. Go opposite first. The eccentric quality of muscle function is critical for efficient and effective movement. The downward pull of gravity has a three-dimensional effect that must be decelerated and controlled in order to produce useful movement. Books teach us eccentric contractions are muscles lengthening while contracting. This description lacks the three-dimensional quality that is required to perform that work. In human motion, eccentric loading must be preloading of the action. The lengthening action of muscle during eccentric loading is best described when the student thinks the muscle is lengthening, stretching, decelerating movement, absorbing the forces of gravity, and storing energy before unloading that energy. Keep in mind, eccentric contractions are a passive reaction rather than a conscious response. Concentric contractions, by definition, are muscle contractions while the muscle is shortening. The basic understanding of this description does not convey the propulsive actions concentric phase of muscle function provides. Concentric forces during human movement are shortening, accelerating, propulsive, and unloading of the harnessed energy. Movement that has strictly concentric emphasis, such as the traditional methods of training, is very inefficient and often leads to overuse issues. Research shows us that eccentric contractions allow the muscles to store between 3 to 9 times more energy than concentric contraction. That principle allows us to harness energy, control momentum, stabilize, and ultimately produce forceful, propulsive moments. Without the eccentric preload of muscle action, concentric unloading actions are inefficient, weak, and effective. Triplane movements. All muscles work in 3 planes of motion and need to be worked in 3 planes of motion. Triphasic action of muscles. All muscles and joints move in 3 planes of motion. All muscles have a triphasic action: deceleration, stabilization, and acceleration. To effectively and efficiently move in all three planes of motion, all myofascial tissue must move triplane load and triplane unload. Muscles are stabilizers. In isolation, muscles become force producers by concentrically contracting to do useful work. Tradition has trained muscles in an isolated, force-producing method, yet when viewing movement, muscles are dependent upon other regions to allow efficient work to be accomplished. The isolated muscle action is virtually opposite of the true action of the muscle in the early phases of upright motion. When viewing muscle action during gait or any other upright motion, imagine watching the activity from below a glass floor. Viewing the foot as it hits the ground and the tibia moves over the foot, the hip moves ahead of the tibia. Rotational aspects, lateral motion, and the forward and back sway of the hips and torso becomes very apparent that no muscle creates during these reactions. Additionally, no muscle concentrically contracts to cause these motions. Rather, the muscles are lengthening to control the momentum, stabilize the joints, harness the energy, and then synergistically have a concentric moment as the body moves slightly ahead of the foot, or when the distal segment is slightly behind the proximal segment during the kinematic sequences. It can be said that when muscles are concentrically doing propulsive isolated actions, they are doing the work. However, when muscles are controlling triphasic, triplane motions, activity is moving in a manner that the proximal segments move over the distal segments, then the muscles elongate to stabilize the joints, and movement are being involuntary reacted. In other words, the muscles are being acted upon. Muscles react to ground reaction forces. The change in ground surfaces, ground effects, undulations, soft surfaces, unstable surfaces cause the foot to react, setting off a chain reaction series throughout the entire muscular skeletal system. Generally speaking, the more unstable the surface, the greater eccentric loading must transpire to control the stability. Gravity infusion. Muscles are stimulated by the effects of gravity along with those of ground reaction forces. For example, the books tell us the abdominals flex the spine. From a supine position, it is true as the abdominals are concentrically contracting and flexing the spine. However, this is vastly different than how the muscles react physiologically. When standing or seated, gravity pulls you into this position, thereby not activating the abdominals at all. As stated above, the muscles first are eccentrically loaded, then concentrically unloaded. When standing and the spine extends to the hip or the hip extends to the spine, abdominals are eccentrically contracted to decelerate spinal extension in the sagittal plane. Physiologic. Based upon the principles above, function is eccentrically loaded first, and a physiological reaction resulting in efficient and economical motions occur. Proprioception enriched. Proprioceptors are stimulated primarily when lengthened, not shortened. For instance, the sedentary, elderly person often has a kyphotic sagittal plane dominant posture and movements. Over time, soft tissue shortens. As they become weaker, have increased soft tissue risk of injury, and the risk of falls increases. As the soft tissue shortens, the proprioceptors match the soft tissue length, and balance and proprioception becomes a serious problem. The fitness and rehabilitation industries have often suggested movement patterns that shorten soft tissue, such as abdominal crunches. However, if we pre-position the client into a right staggered stance, as an example, and have them perform a rotational arm reach at hip height while doing right hip internal rotation, the client will eccentrically load, which lengthens the tissues of the hips, abdominals, spinal rotators, and shoulder girdle. As the client gains more motion, they will gain strength and improve posture. Of course, the trainer must understand how the client moves. Any limitations or compensations that have transformed over time must be taken into consideration. Subconscious. Movements are a subconscious reaction. Through this curriculum, the student will learn the principles and concepts to create an environment for the client's success. These strategies will assist the trainer to develop programs that will produce the desired reaction within the body to activate muscle tissue and enhance performance. And lastly, build the flexibility highways. There are 6 flexibility highways. The anterior, which is designed to improve extension moments. Posterior, which affects flexion moments. The lateral flexibility highway, that will enhance the frontal plane reactions. The anterior X factor, which will improve movements that require extension and rotation. The posterior X factor, which will improve movements requiring flexion and rotation. And the turnpike, which allows cervical spine action along with the opposite shoulder girdle that will connect the same side hip to the neck, that creates a spinal and hip reaction. All of the flexibility highways will be discussed more fully in later sections of this curriculum. Let's discuss the sagittal plane for a moment. We know that the body works in 3 planes of motion: the sagittal plane, the frontal plane, and the transverse plane. The sagittal plane, by definition, divides the body into right and left halves. The movements that occur through the sagittal plane is flexion and extension. So imagine a board that divides the body into right and left halves, and run your arms along the board. You will go through flexion and extension. The frontal plane divides the body into front and back halves. Imagine that board again, now dividing the body into front and back halves. Run your arms along the board and you'll be moving through abduction and adduction, the primary movements in the frontal plane. What's interesting about the sagittal and frontal plane is that they are linear movements. In other words, they're straight line that are greatly impacted upon gravity. Gravity can be a main decelerator of motion through these 2 linear planes. But the most powerful plane of motion is the transverse plane. If we take that board and divide the body into upper and lower halves, we then place our hands on the board and we move our hands around that board or around the axis of the spine. We're going through rotation. Gravity has very little impact upon the transverse plane, and it takes pure muscle function to decelerate movements through the transverse plane. Interestingly, the programs in the fitness and physio industries primarily take place in the sagittal and frontal planes, but yet most of our actions go through not just those 2 linear planes, but through the transverse plane. All muscles, all joints work in 3 planes of motion, and we must train our clients to move through the transverse plane. However, again, tradition has taught us to work primarily through the linear planes. We develop more power. We create more power through the transverse plane. Interestingly, the majority of injuries occur through the lack of control through the transverse plane. We must capture motion through the transverse plane through the 3 primary movement rocks: the foot and ankle complex, the hip, and thoracic spine. We will discuss those functions a bit later in this course. Functional action. All muscles, all joints work in 3 planes of motion. All muscles have a triphasic action: deceleration, stabilization, and acceleration. To effectively and efficiently move in all 3 planes of motion, all myofascial tissue must move through triplane loading and triplane unloading. The characteristics of triplane load are load, stretch, absorb, decelerate, or what's commonly referred to as eccentric contraction. The books don't tell us this. The books don't tell us about the first 4: load, stretch, absorb, and decelerate. For example, please stand up and prepare to jump. As you commence the jumping action, the 24 muscles of the feet lengthen to control foot pronation as a person squats during the loading phase of jumping. The ankles dorsiflex, the knees and hips flex, the spine will slightly flex. As these movements occur, the calf group lengthens to decelerate ankle dorsiflexion. The quadriceps eccentrically load to reduce knee flexion. The gluteal complex stretches while decelerating hip flexion. As the hip complex moves into the squatting position, the hip slightly tilts anteriorly, causing a relative lengthening of the hamstrings. The muscles of the tissue of the spine, especially of the erector spinae, eccentrically load to decelerate and stabilize spinal flexion. Studies have shown tissues store about 3 to 9 times more energy than concentric unload. As you stop moving into the loading or deceleration phase of the jump, there's a momentary stabilization phase when the downward forces stop and the subject begins to accelerate out of the squat moment. When this occurs, triplane unloading of tissue is characterized by shortening of fibers, propelling, acceleration, all commonly called concentric. Remember, the loading and unloading phases take place in all 3 planes of motion. If you were to attempt the jumping motion without ankle dorsiflexion, knee, hip, and spinal flexion, the action would be very apropulsive with very little power, very little efficiency, and very little effectiveness. Now, as we perceive movement, as we start to relate to movement, and as we need to understand this aspect as it relates to functional assessment, we must understand the relative bone position of the lower extremities. Movement is described as the distal bone in relation to the proximal bone. When describing movement away from the spine, we need to view the relative position of the bone segments that make up the joint. Movements away from the spine, as stated, are described as the distal bone in relation to the proximal bone. For example, in the left photo, notice that the femur is adducted to the ilium as the left leg is moved to the right into hip adduction. In the right photo, see how the left leg is adducted to the ilium. Even though the left picture shows the leg further to the right, don't be confused that the motion is an open chain. The right picture has the left foot on the ground, yet the femur is still adducted to the ilium. Think of distal bone, the femur, in relation to the proximal bone, the ilium. In both pictures, the femur is adducted to the hip and the pelvis. Spinal movements are described as the proximal bone segments in relation to the distal bone segments. For example, in the left photo, this demonstrates the head turned to the left, which in reality positions the upper cervical vertebra rotated further than the distal vertebra, thereby describing left cervical rotation. This movement is a top-down action. In the right photo, the head is forward, but the lower vertebral segments are rotated to the right, which in actuality, by its definition, places the cervical spine into left cervical rotation. This is due to the fact that the proximal bone segments are relatively left to the rotated right distal bony segments. Again, let's repeat that. The proximal segment, which is towards in the cervical spine and towards the head, are rotated left to the right rotated distal bony segments. It is essential for the student of human movement to understand this concept, as it will be important to allow the joint's proper motion, especially if working with an injured or sedentary population. Often with these clients, the trainer needs to create an environment for success, and at times we may have to pre-position the clients into certain joint positions and perform remedial movement patterns prior to commencing with a more advanced progressive action. So in this case, both pictures show left cervical rotation. All muscles, all joints work in 3 planes of motion. Books don't tell us that. This particular slide to me is my most important if I want to appreciate and understand how the body moves from the ground up and the top down. To me, this is the roadmap to unravel the complexities of what goes on in the body. What this shows is each joint that works in 3 planes of motion, the sagittal, frontal, and the transverse plane, and how each joint works within each plane of motion, but also how it's dependent upon other joints above and below. For example, let's look at the knee. To load the knee, we see that the knee in the sagittal plane will flex. Everybody knows that. However, what we have to also understand is that as the knee goes into flexion, take a look at what's happening at your ankle. Don't look at the slide, take a look at what's happening at your ankle. You see that your ankle is dorsiflexed. Forget about the PF for the moment, just look at dorsiflexion. So we see, to make the knee successful, to create an environment for the knee to be successful, the ankle has to dorsiflex. Let's just test it for a moment. Draw your knee behind your shoelaces as an example, and try and do your squat or your lunge now. You see that this isn't a very successful squat or a lunge. But in order to make the squat or the lunge successful, the ankle must go into dorsiflexion. When I see clients who tell me their physician or their physios have told them not to squat, the first question I have to ask is, why? One of the first things I look at is what is going on at the foot and the ankle complex. Because to me, the knee is the dumbest joint in the body. It's going to greatly depend upon what goes on at the foot and ankle and what goes on above at the hip. So we see in the sagittal plane, as the knee flexes, it is loaded. Or as the knee loads, it goes through flexion. Now, find your tibial line. Find the tibial line, or what we commonly call the shin bone. As you go into knee flexion, under normal healthy conditions, we're not talking about a flat foot or a high arch foot. Under normal healthy conditions, the tibia goes into internal rotation, it rolls in. By definition, if you recall in our previous slides, movement is described away from the spine as the distal bone in relation to the proximal bone. So in this case, we see that the tibia is rolling in, tibia is distal to the femur, and we have internal rotation of the tibia. In the frontal plane, everybody imagine you're a marionette. I'm holding your strings, and now we let go. As you collapse down, notice where the knee goes. The knee joint moves towards the midline, but don't be fooled by that. Look at the distal end of the tibia in relation to the distal end of the femur. We see that the tibia is lateral to the femur. Therefore, by definition, distal bone in relation to the proximal bone, the tibia is lateral or abducted to the femur, the knee is abducted. To make the knee successful in all 3 planes of motion, we have to go through knee flexion in the sagittal plane, knee abduction in the frontal plane, and internal rotation in the transverse plane. Let's move up to the hip for a moment. We see that as the knee is flexed, the tibia has gone into abduction. The femur is in internal rotation. The femur is flexed to the hip, so we see that the femur in relation to the ilium is flexed, so the hip is flexed in the sagittal plane. The femurs have gone into internal rotation in the transverse plane. And when we look at the femur, the distal bone in relation to the ilium, we see that the hip is adducted. So in order for the knee to be successful, the hip better be doing its thing and become successful. And a lot of this is dependent upon what goes on at the foot and the ankle complex. We'll talk about the big movement rocks with the foot in another slide. But again, we need good ankle dorsiflexion to allow the knee to flex, to allow the hip to optimally flex and load and internally rotate and adduct to load the glute, to flex, internally rotate, and abduct to load the knee. This slide is my most important slide. This is my roadmap for success. Anytime I do a gait and motion analysis, anytime I'm watching people do any type of activity, I must keep this slide constantly going in my mind. When I was first starting to study movement, and I'm still studying movement, I took this slide, I went in front of a mirror, and I was just moving around. I was reaching, I was squatting, I was lunging, I was doing various movements, and I would stop to see where one joint segment is in relation to another. excuse me, I highly suggest that you do the same. Don't try and memorize the slide. It will not mean anything. We need to internalize it. We need to feel it. We need to understand from a distal to a proximal approach and also a top-down approach of how motion is going to affect joints. You can do this. Good luck. And again, if you appreciate this, if you start to internalize this particular slide, it will open up an entirely new paradigm of how you will look at people, how you will analyze people, and how you will create program design. In many of our textbooks, in many of the curriculums, we've seen this diagram of the human body that's divided in three planes. We've got a board. Think of a board that divides the body in right and left halves. That makes up the sagittal plane. Think of that board that when you run your arms along that board, the movements that occur in the sagittal plane is flexion and extension. Then we have a board that comes and divides us in the front and back halves. If you run your arms along that board, you have AB and adduction in the frontal plane. So the frontal plane is divided by front and back halves of the body. Then you have a board that divides us into upper and lower halves. Think of the transverse plane as dividing the body into an upper and lower half. You place your hands on that board and you turn your hands on the board. You're going through the transverse plane. Program development has been, I believe, using only half the movement spectrum. We understand these planes, but invariably, at least 90% of the time when I ask the question at presentations and conferences where I present, is take your arm and go into a sagittal plane movement. Invariably, the majority of people, at least 90%, always go into shoulder flexion. But don't we ever go into extension? This is a sagittal plane movement. So we're only using half the movement spectrum. Then I ask, let's do a frontal plane movement. Invariably, people will go into abduction. And that's same side lateral, which I agree with, but don't we at times go opposite side overhead lateral? Because this is still part of the movement spectrum in the frontal plane. And in the transverse plane, most people will go one way or the other, but very seldom do both to cover both ends of the movement spectrum in the transverse plane. So my recommendation is, as we look at these movements, think of using the entire movement spectrum, all ends, sagittal and flexion and extension, frontal and abduction, and not just adduction, but opposite overhead lateral, and one way to rotate the other way. Think of same side posterior lateral reach, or same side posterior reach, or opposite side posterior reach. Then we're using the entire movement spectrum, because remember, all muscles, all joints work in three planes of motion. Also remember that we live in a three-dimensional world. What we need to make sure that we do is utilize the 360 degrees, because when we do so, we're going to get motion through the foot and ankle complex, into the hips, into the thoracic spine, and start working our tissues through eccentric loading, stabilize, then concentric unload in all three planes of motion. In many of our textbooks, in many of the curriculums, we've seen this diagram of the human body that's divided in three planes. We've got a board. Think of a board that
To appreciate human movement, we must understand the function of the foot. We have to understand that there's classifications or divisions of the foot. We're going to make this basic and simple. Just think of the foot in the rear foot as the talus that sits on top of the calcaneus. I use the analogy that the calcaneus is a bicycle, the talus is the rider on the bike. Keep in mind that what sits on top of the talus or the rider is going to be the tibia. But for our purposes here, the rear foot is the calcaneus and the talus. The midfoot, we look at the three cuneiforms, the medial, intermediate, and the lateral. There's the navicular bone that's medial to the cuneiform, and laterally is the cuboid. You have 5 metatarsal bones, which are the long bones in the foot, and then you have the phalanges of the foot. The great toe has 2, the lesser toes 2 through 5, each have 3. So there's also looking at the
plantar surface of the foot, there are two sesamoid bones right at the base of the metatarsal phalangeal joint of the great toe. So there are 26 bones in the foot. There's 24 muscles and 33 joints. Here's just an exploded version of the bony structure of the foot. As stated, the great toe has two interphalangeal joints with two sesamoid bones. Toes 2 through 5 have 3 interphalangeal joints. Did you ever wonder why the great majority of ankle sprains and injuries occur to the lateral side of these structures? As the foot hits the ground, the calcaneus everts, placing increased forces upon the medial aspect of the foot, ankle, and subtalar joints. To resist these forces, the medial compartment of the foot-ankle complex has a thicker, wider, and stronger banding by way of the deltoid ligaments, comprised of the tibial-calcaneal, the tibio-navicular, and the posterior tibio-talar ligaments. Compare these ligaments on the medial side of the foot to the lateral collateral talocalcaneal ligaments, calcaneal-fibular part of the foot.
Many of the programs, many of the curriculums, many of the textbooks that talk about fitness programming, talks about program design, really doesn't take into account what goes on at the foot. If we think about it, the foot is the conduit between the ground, and the foot's going to react to ground reaction forces as well as gravity pushing down on it. The foot has 33 joints, 26 bones, 24 muscles, and those muscles want to be eccentrically loaded first. They will stabilize and then concentrically unload. We have to understand what goes on at the foot, because I'm a firm believer that if we have foot dysfunction, we're going to see dysfunction throughout the entire kinetic chain. I've seen many cases, people with knee pain, hip pain, low back pain, have a foot issue, a foot problem. In the fitness industry, I believe we just need to understand 4 major components. If there's any pathology, we must refer that out. But the 4 major components is understanding what is going to happen at the foot to create an environment for the entire system to become successful. Those components are, think of it this way. As the foot hits the ground, gravity is going to take the foot and drive it into the ground. But to make the system successful, to turn on the glutes and to make the hips function properly, to make the low back function properly, what the foot must do is go through calcaneal eversion. As you go through calcaneal eversions, the foot again hits the ground and the foot starts to flatten out as we dorsiflex into mid-stance. Calcaneus is going to evert and the tibia is going to internally rotate. If you look at it from the side, you're going to see the foot hit the ground. Dorsiflexion occurs as the hip goes over the foot. Look at it in this respect. Foot hits the ground, hip moves over the foot, undorsiflex at the foot and ankle complex. So we have calcaneal eversion, dorsiflexion. That is going to cause tibial internal rotation. Think of it this way. You have the calcaneus, and you have the talus that sits on top of the calcaneus. Think of the talus as a rider on a bicycle. As that bicycle starts to lean one way, the bottom of the tire goes outward. Think of that as pronation, because pronation is the bottom of the calcaneus is driving laterally. But the bone itself is driving medially, but the bottom, which is the tire, is driving laterally. We look at it in this respect. So as that happens, the talus is going to dive in, because you as a bike rider, as your bike starts to tilt, you're probably going to look to see where you're going to go. Now on top of the talus, think of a long helmet. That long helmet is called the tibia. As you as the talus turn one way, that helmet is going to turn with you, and the tibia is going to internally rotate. So we have 3 components going on so far. We have calcaneal eversion, dorsiflexion, tibial internal rotation. Now here's the last concept, and that's forefoot abduction.
If you recall, when we look at movement away from the spine, we look at the distal bone in relation to the proximal bone. In other words, we see that the long bones, the tarsals, and we see the phalanges are going to go abduction or lateral to the calcaneus. But there is no real motion, such as the arm right now is going into abduction. There is no real movement, but relative movement when we go into forefoot abduction when the foot hits the ground. And the reason I say that is as the foot hits the ground and the calcaneus dives in, remember the calcaneus is moving probably further and faster than the forefoot, creating forefoot abduction. So in reality, we have relative forefoot abduction as the calcaneus moves medially. So as a review, the four big rocks that we need to make sure the foot is going through is calcaneal eversion, dorsiflexion, tibial internal rotation, and forefoot abduction. If any one of those components gets limited in motion, you will see that the system is going to become limited in motion, and that's when we often develop compensations. Once we get those motions, and the tibia internally rotates, and the knee is going to abduct, and the knee is going to go through internal rotation, and the femur will internally rotate, and the femur will abduct, and then we flex. The gluteals are maximally loaded in 3 planes of motion. That occurs all because of the success that has been created by the foot. As a previous video clip demonstrated, there are 4 big rocks of foot function that needs to occur in order to allow the hips and gluteal complex to become optimally activated. These 4 big rocks are calcaneal eversion, dorsiflexion, tibial internal rotation, forefoot abduction. If any one of these components becomes limited in motion, the entire chain reaction will be suboptimal in its ability to adequately load. Often the compensations ensue and the risk of injury increases. This portion of part 1, we're going to start to explore functional anatomy. This particular segment is going to discuss the lower extremity. The next few slides show the origin, the insertion, the functional action, and the anatomical action of the particular muscle groups. Also pay particular close attention to the fascial connections, the synergistic relationships that occur and that are developed through the architecture of the musculature. Pelvic girdle is comprised of the two innominate bones, the ilium and the sacrum, and the femur on each side. Historically, movement was considered in an isolated manner of one hip action separate from the opposite hip action. Contemporary viewpoint and functional actions reveal the pelvic girdle is actually an interconnected pelvic ring that is attached by the soft tissue of the pelvic floor, hips, legs, and into the lumbar spine. Considered to be one of the most mobile regions of the body, the hip must have adequate motion in all three planes of motion, as well as the ability to glide in three planes of motion. Integrated function of the hips is dependent upon the actions of the foot-ankle complex, lumbar spine, and thoracic spine. Additionally, immobility of the hips can lead to low back dysfunction, thoracic spine problems, and shoulder injuries. These concepts will be discussed in subsequent sections of this curriculum. Please take the time and study the functional anatomy of the following 4 slides, reviewing the musculature of the hip complex. The abdominal complex is part of the central unit and crossroads of the body. It involves the 4 primary abdominal muscles, the rectus abdominis, internal and external obliques, and the transverse abdominis. Also, the seldom discussed pyramidalis is viewed and acts to tense the linea alba. Historically, the abdominal complex has been trained by flexing the spine against gravity, typically in a supine position. However, functional reactions teach us that the abdominals react in all 3 planes of motion by decelerating hip and or spinal extension in the sagittal plane, lateral flexion in the frontal plane, and rotation in the transverse plane. Review the following 6 slides to study the functional anatomy, fascial connections, and the synergistic structural relationships of the abdominal musculature. The next slide reveals the interrelationships and synergistic functions of the abdominal complex from the anterior and posterior anatomical aspects. The transverse abdominis, the internal oblique, the external oblique, the rectus abdominis, the pyramidalis.
Often referred as the scaffolding of the body, the spine is anything but stable. In fact, it needs to be very mobile. The axial skeleton includes the skull, vertebral column, ribs, and sternum. Not only does the spine provide for our framework, but it is critical in shock absorption. When viewing the spine from the lateral side, it is apparent that the spine has a native S-curve to its structure. The purpose of this natural S-curve is primarily for shock absorption and to mitigate the forces placed upon the spine and the body. The positioning of the spine is greatly impacted by the motion and position of the pelvic girdle, which will be discussed later. The spine is compartmentalized into 3 regions, even though these areas are an integrated connection of actions. The cervical spine most commonly reacts to actions from below it. Even though there is a natural lordosis in the cervical spine, the majority of shock absorption occurs in the lumbar spine to spare the small, more delicate vertebra in the cervical spine. It is interesting to note, at C1 there is no rotation or lateral flexion, only sagittal plane actions of flexion and extension. C1 and 2 flex and extend, allow anterior-posterior translation, but no lateral flexion. In C2 and 3, they provide for more frontal plane action. Accumulative, there is more motion from C3 through 7, which makes C1 through 3 more successful in the sagittal plane. From a global perspective, the cervical spine allows approximately 35 degrees of sagittal plane motion, which is coupled with the anterior-posterior translation. The cervical spine is nearly 20 degrees of axial rotation and about 30 degrees of lateral flexion. The thoracic spine is one of the most mobile regions of the body. Many dysfunctions result due to the lack of motion in the thoracic spine, especially injuries to the lumbar spine. When looking at the segmental motions of the thoracic spine, it is interesting to note the limited sagittal plane action in the upper segments from T1 through T5-6 regions. Each level has approximately 4 degrees of motion, or 24 degrees accumulative. However, notice the increased range of motion starting at T6-7 at 5 degrees, gaining to 6 degrees at each level from T7-8 through T9-10, totaling 23 degrees. At T11-12, there's about 9 degrees and 12 degrees at each level of T11-12, T12-L1. At the distal end of the thoracic spine, the range of motion totals 33 degrees of combined flexion extension. In total, the thoracic spine allows 76 degrees of flexion extension combined. It is interesting to note the range of motion in the sagittal plane increases as it moves and merges towards the lumbar spine, which is very conducive to flexion extension action. In the frontal plane, there is 54 degrees of lateral flexion from T1 through T10. From T11 through L1, there is 24 degrees of combined lateral flexion, totaling 80 degrees of frontal plane motion in the thoracic spine. This is critical to maintain, as frontal plane action is necessary for transverse plane motion. The transverse plane is ample in range of motion at levels T1 through T9, totaling 80 degrees of combined rotation to both sides. Interestingly, the lumbar spine is not conducive for transverse plane actions, and the thoracic spine significantly reduces its motion from T10 through L1 as it converges toward the thoracolumbar junction. Notice why the lumbar and thoracic spine has limited motion in the transverse plane. If you look at the facets of the lumbar spine, you see these are very narrow in movement, and I call them similar to the blinders on a horse. You look at the transverse plane articulating facet, it allows for greater range of motion at each level. The transverse process of both, you see the lumbar spine
does not allow for great motion in the transverse costal facets. The lumbar spine has ample motion in the sagittal plane, a combined 68 degrees of flexion and extension. Note the increased extension motion as it converges with the lumbopelvic junction. In the frontal plane, there is 29 degrees of frontal plane action, with very limited transverse plane motion of 13 to 15 degrees of movement. Due to the limited transverse plane motion, it is critical the rotation moments of movement come through the hips and the thoracic spine to spare the lumbar spine of excessive movement and increased risk of injury. A couple of points worth noting is the spine is greatly affected by the pelvic actions in the feet. When the pelvis moves into anterior, make that posterior pelvic tilt, the lumbar spine will flex upon the pelvis and reduce its lordosis. Simultaneously, the thoracic spine will flex further and the cervical spine will flex. This increases tension upon the posterior longitudinal ligaments, myofascial structures, and the posterior flexibility highway, which will be discussed in part 2 of this curriculum. Likewise, when the pelvis moves into anterior tilt, the lumbar spine will increase its lordosis, the thoracic spine will extend, and the cervical spine will increase lordosis as well. If within the normal physiologic limits, this will provide for greater shock, will allow for greater shock absorption in actions such as running or jumping. When considering back or spine conditioning, it is important to think in terms of whole body movements to allow improved joint stability. Stability for one joint segment may require mobility at another. If one area becomes immobile, another may have to become more mobile to compensate for that adjacent immobility. When analyzing the bony architecture of the thoracic spine to the lumbar spine, it is very apparent the transverse processes of the thoracic spine are nearly 45 degrees angled from the vertebral body, allowing more angular and rotational motions. The lumbar spine articular processes are less angled, resulting in less motion in the transverse plane. These tables are just demonstrating ranges of motion in the cervical spine. This reference is from the Mechanical Properties of Human Cervical Spine as shown by three-dimensional analysis of load displacement curves by Panjabi et al. The next few slides are showing the architecture and the musculature of the spine and the back. Please take time to study this and look at the interrelational fascial connections and the synergistic network that takes place within the system.
The next slide shows a layered view of the shoulder girdle complex and the synergistic fascial relationship from the anterior and posterior views. Study the following 6 slides to appreciate the fascial matrix of the soft tissue that comprises the shoulder girdle complex. Interestingly, the musculature of the neck is intricately involved in shoulder function, especially with the close proximity of the levator scapulae with the supraspinatus and rotator cuff. Please be sure to review the previous slides of the trapezius, latissimus dorsi, and rhomboids, as these are considered part of the shoulder girdle complex. Our next module is going to discuss the 6 flexibility highways, the anterior, posterior, and lateral flexibility highways, the anterior X factor and posterior X factor, and the turnpikes. What we're going to look at is not just how these particular flexibility highways affect movement, but how they are affected by the fascial lines and how it will enhance movement by understanding these synergistic relationships.